Okay, we're now live. I have a dozen cases for you. It's Thursday night. Happy Easter, happy Passover. Back pain. 20-ish-year-old, you can see the patchy enhancement in the patient's left kidney, the right kidney small and atrophic with a staghorn calculus. When you look at the left kidney, it's clear, it's enlarged, there's patchy enhancement. It does not really make you think about a tumor. Transitional cells can be infiltrating, but it really doesn't look like it. It really makes you think about infection. Here it is on the 3D coronal views, the atrophic right kidney, the big left kidney with patchy decreased enhancement. A really nice example of acute pyelonephritis, which in this case was due to E. coli, a common pathogen. Next case, hematuria. If you look hard, you can see a low density zone in the patient's right kidney. You give IV contrast, beautiful example of a hypervascular mass. Now, there is a central scar or necrosis, so you could think of an oncocytoma. Very, very well defined, so an oncocytoma might be a thought. But again, it's renal cell till proven otherwise. There's the washout. That scar does remain. Sometimes with oncocytoma, it disappears. Central scarring and necrosis not uncommon in renal cell. Here's the excretory phase. Again, you can see well-defined lesion. This was the cinematic rendering, just focusing on the mass and its extreme vascularity. And this was a beautiful example of a clear cell renal cell carcinoma. Again, you want to be careful. It also shows how easy it might be to overlook this lesion on the non-contrast scan. Nausea and vomiting, younger patient. What you see in this example is the duodenum is dilated. Transition point where the SMA is, and the SMA to aorta angle is decreased, particularly well shown on the sagittal view. Now, some patients have decreased SMA angle. They may have lost weight, they may be skinny. There's a number of causes. To me, SMA syndrome is only diagnosable, or at least suggestible, when you see the duodenum is dilated. So in this case, the duodenum is dilated as well. And so my best diagnosis would be dilated duodenum, narrowed SMA angle and distance. I'm going with SMA syndrome, which this was. Another case, abdominal pain. Vascular lesion was initially thought to be pancreas, and it still could be a neuroendocrine tumor off the pancreas. It could also be coming off the duodenum. If it's coming off the duodenum, which in fact this was, you got to think about a GIST tumor or a neuroendocrine tumor. Again, this was referred into us for a pancreatic mass, and it's really almost impossible to say this is not a pancreatic neuroendocrine tumor. This ended up being biopsied. You can see the mass, still vascular on the venous phase imaging, and was a GIST tumor. I like to show cases like this to make the point that sometimes it's not that easy saying if something is pancreatic or duodenal, and how the overlap between GIST and carcinoid and neuroendocrine tumor of the pancreas can be somewhat challenging. Elevated liver functions, you see cirrhosis, you see what looks like a mass in the right lobe of the liver, neovascularity in both right and left lobe of the liver. As you look a little bit more carefully, you can see that the tumor has extended into the portal vein, right? There's portal vein thrombus, neovascularity, cirrhosis, and ascites. Putting all that together, beautiful example on the volume rendering here. Look at the tumor in the portal vein, tumor coming from right lobe of liver, some neovascularity and tumor in left lobe. Very nice for hepatoma with portal vein extension. Another case, mass tail of pancreas. You could go through serous cystadenoma, mucinous cystic neoplasm. You could say unusual IPMN, but this lesion cystic and solid. The patient was younger, and that makes you think about a SPEN tumor, solid and papillary epithelial neoplasm, more common in younger females. We do see them in older females. We do see them in men as well. When you start seeing a cystic lesion like this one with nodularity, I'm always worried about malignancy. I would be really worried, particularly if the patient's a bit older, of a SPEN tumor, or rather a MCN with SPEN being considered. I don't like this for a serous cystadenoma. I'm worried this, with the soft tissue component, would be malignant. And this ended up being a SPEN tumor. Really nice 3D images, including a cinematic rendering, showing you this SPEN tumor in a 20-ish-year-old. And again, important, younger patients, a range of appearance, including calcification, can be cystic, can be solid. When resected, patients have a very high survival rate. So aggressive management with surgery, usually that's all you need, and the patient will have 95+% survival with no recurrence. So just a couple of comments about SPNs, which I won't go into right now. Rule out pancreatitis, abdominal pain. You're looking at the pancreatic head, kind of looks mass-like, right? And then when you look at it and you had arterial phase, not just venous, but arterial, look how vascular the lesion is. And if the patient had an absent kidney and had renal cell, you can say metastatic renal cell carcinoma. If not, I have to go with a clear cell renal cell carcinoma, metastatic to the pancreas versus a neuroendocrine tumor. But as I said, since the kidneys were normal, and you have to assume they're normal, because I'm showing you a little bit of the kidney only, this was a really nice neuroendocrine tumor. Again, think about vascular lesions in the pancreas. I show this case also to show how closely it was to that patient with a GIST tumor, just a little bit different, but the same vascularity. Weight loss, abdominal pain, cystic lesion, head of pancreas, thickened wall, could be necrotic pancreatic adenocarcinoma, could be an MCN, could be an IPMN with high-grade dysplasia, could also be because it's cystic, a SPEN tumor, but with the wall thickening, you really have to worry that you're dealing with malignancy. Here it is on the cinematic and the 3D volume rendered, a view cinematic rendering, and this was an adenocarcinoma. Again, adenocarcinomas are typically more solid, but they can be cystic, and this is a very nice example. Shortness of breath, big heart, all the chambers are enlarged and thickened, poor cardiac output, pleural effusions, infiltrating processes you need to be thinking about, and the classic one that gives you all chamber involvement with enlargement and wall thickening is going to be amyloidosis. Not an uncommon diagnosis, but a hard one to make on CT scanning, more commonly made on MR. Hematuria, and this is the last case. There's a big mass in the bladder with contrast present. You can see it does look like it has calcification, but you cannot be certain it wasn't contrast. But here on the early phase, when you don't see any contrast in the bladder, you see the calcification. Bladder mass with calcification. There's not much more than carcinoma you could be thinking about. Here it is on the 3D rendering with bone removal. Nice example of bulky mass in the base of the bladder with calcification, consistent with a bladder cancer. Very nice example. So that's a dozen cases. I hope you enjoy them. I hope it gives you some thought. Look at them again, think about them, and have a great day, everybody, or a great night.